Thank you, everyone, for joining us today for the Endocrinology Grand Rounds. We are extremely pleased to have Dr. Balamurugan Appakalai present today. Dr. Bala is a professor in the Department of Pediatrics at University of Louisville and leads the Islet Research Lab at the Wendy Novak Diabetes Institute at UofL/Norton. Dr. Bala is not new to us in terms of we know him very well. He has been part of the endocrinology division since 2014 when he joined the UofL Cardiovascular Innovations Institute, where he set up the cell transplant program. He has a lifelong interest in islets, islet transplantation, and islet biology. He obtained his Ph.D. From Christian Medical College, Vellore, studying islets. Subsequently, continued his work in islet biology in Kyoto, Japan, and has worked at the leading institutes in islet work in the United States, including the Starzl Transplantation Institute at University of Pittsburgh, the Barbara Davis Diabetes Center in Denver, and the Schulz Diabetes Institute in Minneapolis before he came to Louisville. Since then, he has been at the Islet Biology Lab, directing it in Cincinnati, and also at the Nationwide Hospital in Columbus, Ohio. We are glad that he's back here. Dr. Appakalai has experience, one of the largest experiences in islet isolation techniques and preserving islets for transplantation to improve their functions. Has done over 2,000 human pancreas islet isolations and 1,000 pig pancreases, 300 monkey pancreases. His interest has been in preserving islet function through this process of isolation and transplantation. He has contributed enormously to this field of research, has over 200 publications to his credit, has won numerous awards and given lectures on this topic at national and international fora. Today, he'll be talking to us on the topic of survival of islet cells in fibrotic microenvironment of chronic pancreatitis, pancreases. Dr. Bala?
Thanks, Dr. Mokshakundam, for your kind introduction, and thanks for this opportunity to talk about how islet cells are surviving in this fibrotic microenvironment. It is generally a highly inflamed environment in chronic pancreatitis cases, how these cells are surviving and maintaining normoglycemia even before pancreatectomy and all. So primarily today, I would like to share my observations of cellular architecture of pancreas from a different type of pancreas based on the literature review, as well as my own experience in performing islet cells from different type of human pancreases. And I strongly believe that my observations will lead to new initial studies. For human clinical islet cell allotransplantation, we accept a healthy brain-dead donor pancreas. So we select the right donor for the recipient. So it comes from a healthy donor. For research purpose, we accept all sort of pancreases, starting from type 1 diabetic, type 2 diabetic, lean donor, old donor, obese donor, plus cystic fibrosis cases, pancreatic lipomatosis pancreases and all. So these clinical pancreas for allotransplantation as well as for research, primarily they come from brain-dead donor. For islet cell autotransplantation, we accept pancreas from, basically the pancreas comes from chronic pancreatitis cases. When we receive the pancreas during islet cell isolation, we extensively characterize or observe the morphological appearance of the pancreas and document all these things in our batch production record. For example, we closely monitor the fat content, blood content, whether the pancreas was flushed well, is there any edematous condition, or the texture of the pancreas in our batch production record. And in the case of islet cell auto transplant, we do more extensive pancreas macropathology, including whether there is a calcification or cyst in the pancreas, and then firmness of the pancreas, whether it is a rock-like pancreas or moderate fibrotic pancreas or a soft pancreas. Plus, we also closely monitor the color of the pancreas, blood content, fat content, and the nature of the duct, whether the duct is dilated or normal, or sometimes we see calcification in the duct. And we also closely monitor the extent of fibrosis with a scale of 1 to 10. And all this information goes into our batch production record. So for the basic method of islet isolation is intraductal injection of enzyme collagenase to digest the pancreas to release islet cells. Basically, the intact pancreas will become cell cluster at the end. For example, this 100-gram pancreas, we get like almost 40 cc, almost like a 40 cc tissue pellet from this 100-gram pancreas after the digestion with the enzyme collagenase. So in this cell pellet, parenchymal cell mass, we have islet cells, exocrine cells, ductal cells, progenitor cells, endothelial cells, plus all other cells, stellate cells are present in this. And then we purify the islet cells from this parenchymal cells. During enzyme distension step, in the case of brain dead donor pancreas, it is easy to monitor the parenchymal cell mass. My primary goal of this lecture is to talk about the parenchymal cell mass in different type of pancreas and how we can correlate the parenchymal cell mass with the normal metabolic function before and after transplant. For example, in this pancreas, it is easy to see the parenchymal mass. You can see large amount of parenchymal cells. Even if the pancreas is a firm pancreas, sometimes it's difficult to see the mass, but it's the entire pancreas is full of parenchymal cell. I would say more than 95% of the parenchyma is full of parenchymal cells. This table from this data from clinical islet cell transplantation consortium phase 3 clinical trial data showed the average pancreas weight from 75 processed human pancreas from 8 different centers. Those pancreases were accepted for clinical islet cell transplantation. The average pancreas weight was 100 gram, and then the average pellet size obtained after the digestion process was 40 grams. In general, we get 0.3 to 0.4 cc tissue pellet from every gram of pancreas. Basically, the remaining pancreatic content are extracellular matrix and other floating type of cells. In the case of chronic pancreatitis, assessing the parenchymal cell mass is it's very difficult. Isolating islet cells from chronic pancreatitis pancreas poses multiple challenges: alteration in ductal structure, calcification in ducts, and accumulation of fibrous layers are difficult for us to inject the tissue dissociation enzyme into the pancreas. When even during enzyme distension step, monitoring the parenchymal mass or what is the degree of fibrosis, those aspects are a little bit difficult in chronic pancreatitis cases, but we try to monitor the parenchymal cell mass when we cannulate the pancreatic duct. As you see here, this is from a pancreatic lipomatosis case. It's full of fat. Exocrine cells are replaced with fat, so you don't see a duct. This is a typical a minimal change chronic pancreatitis case pancreas. You could see large amount of parenchymal cell. Here, at the same time, in this case, you can see very minimal amount of parenchymal cell, mostly in other areas or fibrotic areas. But if you see these three cases, this one, this, and this, you don't see any parenchymal cell at all. There is a very minimal quantity of parenchymal cell. When I use the word parenchymal cell, it includes islets, exocrine cell, plus even other cells. But interestingly, The islet cells are surviving in this type of fibrotic environment, and they are maintaining normal metabolic function before pancreatectomy. So I'm not even talking about after islet isolation, after transplant, before pancreatectomy, when we touch the pancreas, even in this type of environment, the islet cells are surviving and maintaining normoglycemia. We also do extensive histological assessment after islet cell isolation to see whether our observation is really correct or not. For example, you don't see large amount of parenchymal cell. Here and there, 1 or 2 islets are present. In chronic pancreatitis pancreas, ductal anatomy is completely different. We don't see duct at all in many cases, or we see a large duct. And many times we see calcification in the duct. Again, this is a classical example of large duct. So all these challenges are really harming the islet cells even before the pancreatectomy situation. And histologically, we see large variation in islet plus pancreatic architecture. We see like island of islet cells. Sometimes we see exocrine cells. The degree of fibrosis is different in different areas. In terms of islet morphology, this is a typical normal islet morphology. The islets are stained with diphenyl thiocarbazone. It's a zinc-binding substance. This is the way we see a normal islet morphology. But in many cases of chronic pancreatitis, we see embedded type of tiny islet cells. Sometimes we see some fragmented islet cells. Even the islet morphology are different in different type of chronic pancreatitis. But interestingly, even these tiny islet cells, they maintain normoglycemia or normal metabolic function before pancreatectomy. That's a very unique situation. We don't see it in a brain dead donor pancreas. We see large amount of parenchymal cell. We get large amount of islet cells, but their ability to maintain normal blood glucose level even before transplant or after transplant are different. When pancreas from chronic pancreatitis cases, when it arrives to our lab, we categorize into mild, moderate, and severe categories, depending upon the nature of the fibrous tissue as well as parenchymal cell mass. In terms of islet yield, whenever we have a minimal change from chronic pancreatitis, this gross morphology is comparable to brain dead donor pancreas. And in terms of islet yield, we get large amount of islet cells. The islet yield is comparable to brain dead donor pancreas. And for example, we get more than 4,000 islet equivalents per gram pancreas. So it's a very good number. If the pancreas is 100 gram pancreas, we get more than 400,000. In chronic, degree of fibrosis and exocrine acinar atrophy generally affect the islet yield. For example, from a severely fibrotic pancreatitis cases, we have a low number of islet yield compared to moderate and minimal change cases. And in terms of tissue pellet, ultimately, what is the tissue pellet we obtain from these type of chronic pancreatitis cases? This data from University of Minnesota, you see here in severely fibrotic cases, the parenchymal cell mass per gram pancreas, we obtained like 0.11 cc compared to normal donor 0.39 cc pellet per gram pancreas, or in moderate cases, we get like a moderate amount of 0.23 cc pellet. So the total cell mass from this pancreas is very low. Plus, correspondingly, the islet yield also very low. For example, 2,411 islet equivalent per kilogram was transplanted when compared to islet cells from mild chronic pancreatitis case. In younger donor, we do a lot of pediatric islet cell auto transplants. So In pediatric auto transplants, whenever the pancreas from a younger donor, in general, we get almost larger tissue pellet, like a 0.5 cc per gram pancreas. It is slightly more than our, even from a brain dead donor pancreas. It's mainly because we a lot of islet cells are mantled, or we say like a embedded type of islet cells. So this is kind of our average cell pellet per gram pancreas. Here, if the tissue pellet, the transplanted tissue pellet volume is below 5 cc, evidently the islet number is really low. This is a common observation. If the pancreas is severely fibrotic, we get a low tissue mass, plus evidently we get low amount of islet cells. In my view, this condition is almost similar to how these, it's like a desert condition. The islet here and there, one or two islets are present in this type of desert environment. And these islets are wild. Basically, they can survive even in any type of insult. There is a lot of inflammation went into here, and acinar cell autolysis plus various inflammatory reaction always present in these areas. Still, these islets are surviving in this fibrotic desert environment and maintained normoglycemia before pancreatectomy. So this is a classical example. This is a completely different. When we do decellularization process for our research pancreas, we remove all the cells and take the skeleton of these extracellular matrix for our research purpose to recreate the home environment for islet cells. So this environment is almost like this. It's like a full of only extracellular matrix, and here and there, a few islets are present. I see this phenomenon with the chronic pancreatitis cases. And again, this is one case study in which there is a very limited number of islet cells in this particular pancreas. It's mostly fibrous area. Again, the patient was maintaining normal blood glucose level before pancreatectomy. And this is another classical example. You see in this entire pancreatic area, mostly fibrous tissue, some exocrine cells, and the brown stained ones are insulin stained islet cells present. Again, this is another example. Patient was maintaining normal metabolic function before pancreatectomy, even with the limited number of islet cells. So that's why we want to bring this idea or the concept or super islet cells existing in chronic pancreatitis pancreas. So whenever, for example, this is a normal pancreas, it's a 95% of the cells are parenchymal cell. In this, large amount of islets are existing. And this is a mild fibrotic case in which we have only 40% parenchymal cell. From this 40% parenchymal cell, we got 10 cc tissue pellet. In this case, from a same 100-gram pancreas, we got 40 cc. But the pancreas like this, it's only 5% parenchymal cell, and the tissue pellet we obtained was just 1 gram from a 100-gram pancreas. However, the patient was maintaining normal blood glucose before pancreatectomy. This is the data from Dr. Moksha Kundam, and in which the endocrine department evaluated 60 patients for total pancreas for TPIAT cases from all the referred patients. So it's in that 60 patients, 56% of the patients, they were maintaining normal glucose tolerance. 43% of the patients, they had impaired glucose tolerance test, and some are C-peptide positive diabetes cases. So we don't include diabetic patients for TPIAT. If the patient is maintaining some secretable amount of C-peptide, then the patients are eligible for TPIAT. So this is normal glucose tolerance cases and impaired glucose tolerance test. This is the hemoglobin A1C of 7.3 and 5.5 here. And this is the mixed meal tolerance data from normal glucose tolerance and impaired glucose tolerance. So at minute 120, this is a normal level. This is from impaired glucose tolerance. However, the insulin levels were high even in impaired glucose tolerance test patients. So this is our first 22 patients who have received islet cell auto transplant in University of Louisville in Jewish Hospital under endocrinology and surgery department. Here, I'll give you a few examples. For example, we obtained only 3 cc tissue pellet and we transplanted over 300,000 islet cells. Even with the small tissue pellet, patient was maintaining normal glucose tolerance. However, the pancreas gross morphology was like this. You see, it's a very tiny amount of parenchymal cell, only 3 cc, but maintained a normal glucose tolerance test. Then again, another example from we obtained only 2.5 cc tissue pellet, and then islet equivalent was only 218,000, but patient was normoglycemic before pancreatectomy. This is another example. We obtained 4 cc. The islet yield was very low, only 132,000. As you see here, there is not much parenchymal cell, but definitely there are some islet cells. That's why we obtained 133,000 in this case, over 300,000 in this case, and in this particular pancreas, 218,000. So the islets are scattered throughout this pancreas, but they are surviving in this type of challenging environment and maintained normal glucose tolerance. This is a data from University of Minnesota in which we selected all the small tissue pellet starting from like a 3 ml, 1 ml, even 0.5 cc tissue pellet. It's a very tiny quantity of islet cells for transplantation purpose, and many of these pancreatitis cases, they were normoglycemic. By the time when we process the pancreas, we get a very tiny amount of islet cells. And mostly in these cases, we see only pure type of islet cells, very less exocrine cells. Sometimes we see large number of ductal cells are released along with the islet cells. When we do the histopathological analysis, we see a lot of nestdioblastosis, a large amount of ducts, and ducts are generally released along with the islet cells, but definitely less quantity of exocrine in our cells. For example, so far I showed the blood glucose values before transplant, but in this table we can see that after transplantation, what is the real effect? For example, some patients are completely independent, some are dependent, some are partial function. I'll pick this as an example. We transplanted 3 cc tissue pellet with the purity of 35%, and the transplanted islet mass was less than 3,000 islet cells. But the patient was maintaining basically insulin independent state after 1 year after transplant. Again, another example is from a 2.5 cc tiny pellet completely maintaining insulin independence after transplant. So this particular case, it's from a severe fibrotic pancreas, and we obtained only 1 cc tissue pellet, and the transplanted islet cells functioning very well even after transplantation and achieved insulin independence. And in many cases, there is a partial function. Patient required some minimal amount of insulin after transplantation. And in pediatric cases, pediatric patients, they do very well after transplantation, whether we transplant tiny quantity of islet cell or large amount of parenchymal cell with a large number of islet cells. Many are insulin independent, and we get large amount of islet cells from these pediatric cases. And again, it's important to study how these islet cells are functioning in these pediatric patients, because pancreas is generally small. We get a tiny cell pellet with less number of islet cells, but they really achieve normoglycemia after transplant. Then we also experienced with the different type of chronic pancreatitis cases. For example, this is from a cystic fibrosis that was the cause for this type of pancreatitis. So we see pancreatic lipomatosis. The exocrine cells are completely replaced with fat. So you cannot even differentiate where is the pancreas and where is the fat. So we get like a mass of fat in that. We did islet isolation. Basically, we injected the enzyme throughout the pancreas. There is no real duct. It's just a fatty mass. And after enzyme distension, we got pure islet cell. When we did the histological analysis, we see it's mostly insulin positive cells. There is no other cells, only the fat and some kind of ductal cells here and there. For example, insulin positive cells here in this region, but these are all only fat. So again, cystic fibrosis, pancreas replacement of fat, again, it's a real challenging environment. I strongly believe that these islets are very different from healthy brain dead donor islet cells. It's important to study these type of islet cells in a dynamic glucose challenging test, or using a molecular technology. Nowadays, newer technologies are available to really identify the speciality of these cells compared to brain dead donor islet cells. So we thought that maybe all cystic fibrosis cases had this type of pancreatic lipomatosis. For example, during last week's seminar, Emily Montgomery presented the data from cystic fibrosis cases. In that, she referred if a patient is suffering from cystic fibrosis, the pancreas is almost like a lipomatosis. But in our experience, we didn't see like that. So there was only one lipomatosis case in the entire our islet cell auto transplant series. And there were previously 9 cases of cystic fibrosis. And the pancreas was like a fibrotic. It's not a real fatty mass. The tissue pellet, it's a very tiny pellet. And in many cases, we have 11 plus or minus 9 tissue pellet. And then the transplanted islet mass was also higher in cystic fibrosis. So I just want to bring this point, in general assumption as if cystic fibrosis means it relates to fatty accumulation, but it is not. Many cases are really fibrotic. I don't have a picture to really show, but their pancreas gross morphology was more fibrotic. Then we also experienced similar pancreatic lipomatosis in brain dead donor pancreas. Again, this was the cause of death for the brain dead donor pancreas was cystic fibrosis. So whenever we receive a pancreas from brain dead donor pancreas, it comes with intact duodenum and spleen. The pancreas is again the parenchymal cells are fully replaced with fat. We did islet isolation from this type of pancreas, and predominantly we see large amount of fat during centrifugation process. Basically, we continue to eliminate all these fat after digesting the pancreas. So there is a large amount of, reasonably large amount of pure islet cell population. There is no exocrine cell at all. It's all only islet cells. So we had almost more than 1.5 cc of islet cells from this type of pancreas. So this is the typical islet morphology. Even without purification, it's a naturally purified islet cells without doing any kind of modification in the procedure. We got these many islet cells. Again, because it was from a brain dead donor pancreas. It was not for a transplant purpose. So we did the extensive quality control assessments in their viability, plus insulin secretory capacity, the level of apoptosis, stress markers in islet cells. Plus, we subjected the islet cells to different molecular assays to really see, because it's a very rare sample and compared with our normal pancreatic islet cells. So there was another pediatric patient from 11 years old child. We did a transplant back in 2008. So we obtained almost closer to 150,000 islet cells from this particular patient. So the pancreas was completely fibrotic, large amount of calcification also presented in this patient. So when we did the histopathological analysis of this type of pancreas, we could see large amount of beta cells, insulin producing cells budding from ductal cells. So as you may know, one of the theories for beta cell formation is from ductal cells. For example, this is a CK19 ductal cell marker, the red color, and this is insulin producing cells. So they are not in islet area. So there is just maybe two to three cells are budding from these type of ductal cells. So chronic pancreatitis is a natural injury to the pancreas. So that injury stimulate nesidioblastosis. Basically, we see large amount of ductal cells. So here is another example. The green is insulin staining, and CK19 ductal staining is red color. So the beta cells are within the ductal compartment or adjacent to the ductal area, or just kind of budding from ductal area. This type of observation we see. Maybe in these type of severely fibrotic pancreas, maybe islets are not in a regular architecture. Maybe these type of single cells are present closer to the ductal cells. So during islet isolation, naturally, these cells are washed away during the procedure, because they are not clusters of cells, they are single cells. So maybe I lose these type of cells during the isolation process. Maybe these type of cells are present throughout the pancreas. Maybe we have to do extensive analysis of the pancreas to see whether we see this type of ductal neogenesis. Again, this is another example. You see, this is ductal area. There is a smaller, tiny quantity of insulin producing cells. Again, insulin producing cells within a ductal compartment. You don't see a islet like this, elongated type of islet cell, because it's all closely aligned with the ductal cells. So this may be one of the reasons why they are normoglycemic before pancreatectomy. Maybe the islet cells are scattered closer to the ductal area. So this requires further investigation. We had an opportunity to do some in vitro testing of islet cells from the cystic fibrosis cases, or partially pancreatectomy specimens. The partial pancreatectomies are going in many hospitals for chronic pancreatitis without total pancreatectomy and islet cell auto transplant. So whenever we had a chance to obtain those samples, we isolated the islet cells and subject the islet cells to this dynamic glucose challenge. Basically, we challenge the islet cells with a different amount of glucose or secretagogues or potassium chloride to see what is the insulin response. We place the islet cells, we need only 25 to 100 islet cells for this type of testing. We had an opportunity to test this type of insulin secretion in one time This is just only one example. The red one is from CP islets, basically chronic pancreatitis islet cells. This is a normal islet cells. So we get a similar to intravenous glucose tolerance test, how we do it in humans. When the islets are exposed to low glucose and exposed to high glucose with the GLP-1 stimulation, and bring the glucose to normal level and then re-stimulate the islet cells with the potassium chloride. So we see already a difference in insulin secretion. The only problem is we don't get these kind of islet cells. Generally, during our islet cell auto transplant, whatever the islets we obtain, we transplant. We don't take large amount of islet cells to do more functional assessment. We primarily we use a very minimal number of islet cells to check the viability, but we don't do this type of insulin secretion. Maybe in future, we have to collect the islet cells. We need only 100 islets to do this type of testing to check their insulin secretory capacity. There is a large amount of data are available from a normal brain dead donor pancreas. That's our standard. Whenever we isolate islet cells from brain dead donor pancreas for our research purpose, we do insulin secretory characteristics. Only thing, we have a lot of data. Only thing is, for comparison purpose, we don't have a large amount of data from this type of CP cases. And in recent times, this spatial molecular imaging studies plus spatial transcriptomic tests or methods are available to characterize different cell types. For example, whenever we have the specimens from chronic pancreatitis patients, or if we take a tiny sample, from the sample, we identify the islet area and do the extensive transcriptomic analysis of the islet cells and compare with the normal pancreatic islet cells. So using this technology, we are in the process of studying the differences between these type of super islets or wild islet cells compared to our normal islet cells. And this technology plus there are many newer molecular assays are available to really test their gene expression. Maybe in these islets there is a large amount of insulin secretory gene expression is present, plus a large amount of the PDX expressions are present in these type of islets compared to standard one. So that's we are in the process of doing. To summarize, low number of parenchymal cells. In parenchymal cells, it has all type of cells: islet cells, acinar cells, ductal cells, progenitor cells, are existing in many chronic pancreatitis pancreas. And they either maintain normal glucose tolerance or slightly impaired glucose tolerance. They are not diabetic, even with the minimal number of islet cells. So during pancreas autolysis, when exocrine cells are dying, generally they chew a lot of islet cells, but even then many islet cells are surviving. So this limited number of islets maintaining either normal glucose tolerance or near normal or impaired glucose tolerance in many severely fibrotic cases. And for future direction, I would suggest, apart from mixed meal tolerance test, if we can do extensive metabolic functional analysis from those evaluated patients. For example, how do we really select those patients? Whether the patient will have this kind of severe fibrosis or not. It's easier to see through the images. Whenever there is a word calcification in the pancreas or dilated duct or atrophic condition of the pancreas, those three conditions are always associated with the severe fibrotic pancreas. So the images are always available. When there is a calcification already present in the pancreas, maybe that's the best patient should undergo extensive metabolic assessment. And once the pancreas is removed, we would like to do more histological analysis to see whether is there any ductal, different type of islet cells are scattered in the pancreas. Plus, whenever there is a possibility for us to collect the islet cells, we would like to do in vitro insulin secretion from those islet cells to see whether they have a high insulin secretory capacity. So with this, I stop here and I thank UofL team, endocrine team, and Norton team for providing an opportunity for me to return to Louisville. So I would be happy to collaborate with you all. Thanks for this opportunity. Thank you.
Thank you, Bala, for an excellent talk and with all the rich experience that you've had with islet isolation and transplantation. I think this is a very important topic, which we have been struggling to figure out why some do well and some don't, and so one of the things that I had a thing was whether does the cause of the pancreatitis have anything to do with the islet function itself?
I don't know the answer, but definitely it's one of the areas we can really explore. Whether historically, not much genetic analysis were done, but in recent times, I see whenever patients are, especially pediatric patients, whenever they are suffering from mutation, genetic mutation, the pancreas is really bad, even at the age of 4 years, 5 years. So alcoholism in adult cases, generally it is associated with severely fibrotic nature, poor quality of islet cells from those ones. In pediatric population, due to genetic variation, we see very bad severe fibrotic cases. Maybe it's a real opportunity to test those ones.
I have a couple of questions. Wow, that was a great overview. One is just the same issue that you had earlier talked about. I was surprised that the pediatric cystic fibrosis pancreases that you have, so many of them, because the adult patients, I'm part of the adult endocrine. I'm the endocrinologist for the adult CF center here, and we have about 120 patients, and I see at least 40 of them for diabetes, and the rest for bones and other issues. And I haven't had any patient who has undergone surgery or any intervention other than maybe BRCP or such. Most of them have exocrine pancreatic and then undergo the oral glucose tolerance, then get diagnosed and we treat them. Either they are impaired glucose tolerance or, full-blown CFRD. So I was just surprised at the amount of pediatric.
Actually, maybe I didn't specify. It may not be many pediatric cases. The one particular one, very quickly.
The lipomatosis.
Pancreatic lipomatosis was from definitely it was from pediatrics. The other cystic fibrosis auto-transplanted cases.
Okay.
Those ones, many are adult. I wouldn't say they are pediatrics.
Okay.
So now let's say maybe now I have done maybe 200 cases of pediatric auto transplants. In those cases, how many times I see pancreatic lipomatosis? Very rare, maybe one time. And cystic fibrosis, yes, we see several cases of cystic fibrosis. They are all fibrotic type of pancreas. But we don't see many.
Okay. Yeah. Most of the children you see are mostly genetic, like the Sphinx mutation.
Yes. The PRSS1 mutation.
And maybe CFTR by itself. Yeah.
Exactly.
And then when you talk about I should know this after working with your team for the last 10, we've had this for the 10 years, right? 2014 was the first islet transplant we did here with that patient. So when you talk about islet equivalence per kg, it's the weight of the patient, right?
Yes. So at the end of our islet isolation, we will have a total number, let's say 300,000 islet cells, then divided by the
Weight of the
recipient weight to give, because that way it's easier to study their outcome.
Sure.
Whenever they received less than 5,000 islet cells per kilogram body weight, they don't maintain normoglycemia for a longer period of time compared to if they receive more than 5,000 islet cells. Generally, they are normoglycemic for a longer period.
But it was very interesting when Dr. Mokshiganam was sharing the data of the 60 or 70 patients that were underwent, how some of them, like following them over 10, now probably it's the 11th year for the first patient, is many times the number of islets per kilogram sort of didn't predict the outcome of insulin independence. So maybe it's the super islets, perhaps, or
I think we are changing that the whole, instead of going with islet equivalent per kilogram body weight, what was the tissue pellet we really obtained?
The one you showed.
Yeah. For example, I strongly believe if the tissue pellet is less than 3 cc, we may not achieve long term.
Even before you degrade them in the OB or whatever, before the first.
Yes, that's the first step.
Before you put the collagenase.
No, after collagenase, because I need to separate the islet cells from the intact pancreas. That's after collagenase digestion. But it's not purified islet cells, just extracted from the pancreas, and then how much pellet we got. So, and I have been discussing with the islet TPI-80 groups to see maybe we have to go with the tissue pellet volume. We have to because that analysis is not included in many studies. What was the pellet? I believe like if I transplant more than 10 cc, at least they will have an opportunity to maintain some normoglycemia for some duration.
My other question was, you showed the in vitro GLP, high dose, low dose glucose, and then putting in GLP-1. So in there, I should probably have asked Dr. Mokshiganam this, but when it's embedded in the liver capsule, the GLP-1 crosstalk, does that happen from the gut to the new islets? The way it works with the pancreas?
I don't know.
Like endogenous GLP-1 by the patient, how it improves insulin secretion, right? That is the normal sort of physiology. But when the islets are embedded in the liver capsule, is the same sort of methodology work?
I don't know the answer to that question.
I just thought of it as you were
like in general, whenever we do insulin secretion, in vitro insulin secretion assays, we try to challenge the islet cells with a different type of compounds, like many times arginine, talbutamide, like a different levonclamide, different type of even drugs to see whether. So in that particular experiment, I think we challenged the islet cells with GLP-1, but how the endogenous GLP-1 and how it affects the transplanted islets in liver, maybe I don't know.
The endogenous islet, if you do a transplant, you will see more GLP-1 because GLP-1 will be secreted into the portal system. And so the islets in the liver will see a higher amount than the pancreatic islets, because the pancreatic islets will get their circulation through the artery, through the pancreatic artery. However, the study that he showed was the islets were isolated and they were perfused. or perifused, So they were in a chamber. So they were isolated, and then they used a constant infusion, constant amount of GLP-1 to kind of, use as a base for looking at before and, with GLP-1, without GLP-1, how much glucose will stimulate the insulin production. So that's different. Whether that'll make much of a difference, we don't know, because in animal experiments, trying to use GLP-1 to improve islet survival or function hasn't worked that well, So I think GLP-1 has a modulatory role. It's not a prime determinant of its function as such.
That's right.
That's why, because initially it has been tried in cultures to see if we can make it do well, survival, all of those things, and doesn't seem to do too well, any better. So we don't know the exact factors that we
Plus
need
the
to put in.
half-life of GLP-1 that you do in vivo is very short, right?
Correct. I mean, but here they're perfusing it, so it'll be there. I mean, they're adding it all the time. So it's an infusion. So it will be, it should be okay.
Yeah, in vitro level, they are active because the total duration of the study will be only 3 hours maximum.
Yeah, but those are all fascinating areas to look into. The more you do this,
Definitely. I think it's a new area for us to really explore.
Yeah.
Is there within the same pancreas, there are variations, correct? There will be areas of desert, islets. Is that related to fibrosis, or there are desert areas where you don't see much fibrosis, and there are areas of fibrosis where you still see many islets? So fibrosis is not the main determinant of how much islets or what the function are.
I'm sure histologically we see a lot of variation. Sometimes we see a fibrosis and a group of islet cells in one particular area. In another pancreas or another area of the pancreas, we see large amount of exocrine cell without any islet cells. The pattern is very different.
Yeah. So it's fascinating as to how these islets function and how they don't function. So maybe there are some exocrine or parenchymal factors. So looking at not only just the islets, but also looking at the pancreatic gene expression in the non-islet cells would help figure out what may be keeping them alive or killing them.
And the other aspect I want to mention to you, how you classified them into normal glucose tolerance, impaired glucose tolerance. Even that kind of data is not available in the literature, even from Minnesota. So they combine into one. This is the metabolic function before transplant. So they didn't separate it into 2 categories. I think this separation is very helpful to see.
Yeah, because on the other thing, when you notice, is that the ones who had good function later were also lean, So BMI seems to be means they probably are more insulin sensitive, so they needed less insulin, So there may be a very interaction between insulin secretion and insulin action that determines how well it might work,